let's get started. Welcome everybody at a new Bytes of Innovation webinar. Bytes of Innovation is powered by Segmed, which is a company that provides real-world imaging data to researchers. Bytes of Innovation, we invite key opinion leaders to talk about the future of healthcare. Bytes of Innovation is hosted by Dr. Aline Lutz, who is the Vice President of Medical Affairs at Segmed, and by myself. I'm co-founder and Chief Scientific Officer at Segmed. We, like I said, always invite key opinion leaders. The next time will be November 6th, where we'll have Dr. Pranav Rajpurkar, who is a professor at Harvard and also co-founder at A2Z Radiology. And then shortly after November 12th, we will have Tim Stick, who is a professor at University of Wisconsin Medicine and also co-founder and CEO at Red Unity. But today, I am proud to announce that we will have Dr. Yin Ho amongst us. And Dr. Yin Ho recently, or actually not recently, will very soon publish a book called Rushing Headlong, Health IT's Legacy and the Road to Responsible AI. And exciting, one of you all here will actually get the book because we will do a little lottery after the webinar. So who's Dr. Yin Ho? She is a physician turned entrepreneur and visionary executive. She's led transformative health IT and clinical research companies for over 25 years, and including she was the interim CEO at Veradigm. She also co-founded Context Matters, which is the pioneering health economics data analytics platform that is now part of Clarivate Analytics. Before that, she led eHealth at Pfizer. She guided metadata strategy through an IPO, and she held senior leadership roles at Aetion. She is a trained physician. Actually, she's a trained emergency physician at Yale, and she holds an MBA from Harvard. She's very busy, as you can see. She advises many AI healthcare companies, and at Segmed, we're actually fortunate to have her serve at our board of directors. So during this webinar, we will talk about her book. Let me get Aline and Ing to the room, and I'll stop sharing my screen. Welcome Ing and Aline. Great to have you here. Before we dive into the book, my first question to you, Ing, is you have an extraordinary background. You're trained as a physician, you have an MBA, you were a founder of a company, you've had executive roles at larger companies. What was the driving motivator for you throughout your career so far?
Well, first of all, let me thank Martin and Aline for inviting me on today. It's really wonderful to be here. It's a great question, and it's a hard question sometimes to answer, but suffice it to say, I trained as a physician during right up to the beginning of the .com run-up, and I was very excited about healthcare information technology, especially about the idea of solving an asymmetry problem. And so, as I sort of mentioned in my upcoming book, I really wanted to get involved. And so in doing so, I kind of rushed headlong into getting into the space. The best way I could do it was to go to business school and step into the .com fray myself. And that's how I ended up getting involved, and why I left medicine to basically bring a physician sensibility to the health IT space as it was growing up.
That's very interesting because we're sitting here actually with 3 physicians who are all not practicing anymore. I think that's actually pretty unique. So we got a unique population here. Yeah, it's good to have a specific target and really go after that, of course. So that's exciting to hear. One question, just like a more general question, what was it that motivated you to write this specific book, and why did you do it now?
So it's interesting, when you keep going along inside of an industry for a while, you sort of assume everybody knows all the issues that are coming along until you suddenly stop one day and realize that you've been in it for so long, you've forgotten that not everyone who joins a space actually understands its history. And so I think that became very apparent to me last year when I was the interim CEO of Veradigm. And I was trying to describe to a number of people about why it was such a pivotal moment to involve generative AI into electronic health records, largely to actually liberate the data that existed in the EHRs, so that you could actually use it for clinical research. And I do remember, for anyone who had been in the space for a while, they completely understood what I was saying. But for anyone who had sort of entered the space sort of adjacently or separately, or perhaps a little later, they kind of looked at me strangely and did not completely understand where I was coming from. And I think it was based on that and the recognition that generative AI developments were going to move so quickly, and they have been moving so quickly, that it was important to give the context of the history of how we got to where we got to around health IT, so that you would even want to look at an opportunity as trying to involve generative AI to support clinical research.
Awesome. Yeah, it's a great way to get that foundation of, hey, where are we actually coming from, and then to understand what can we do in the future.
Yes.
Okay. Aline, I'm handing over the mic to you to talk about the first part of the book.
Thanks. Thanks so much, Win, for being here and for sending a copy of your book. I read it with great interest, a lot of great insights from it. So as a first question, in the book, you talk a lot about health IT history, and I'm curious about the idea of the IT evolved around billing first, patient second. Can you tell us a bit more about how this happened and how it affects what we have today, specifically regarding health data?
Absolutely. So what's really interesting is when people think about health IT, they tend to only think about electronic health records, or they tend to think about the infrastructure that supports patients, physicians, and hospitals and clinics, and also the payers. And that's sort of the assumption that that is the health IT infrastructure, when in actuality, there are two health IT infrastructures, one really around care and one that's really around research. And for anyone in research, there is a recognition that we've been using electronic tools for quite some time, electronic information tools for clinical trials, for observational studies, for capturing any kind of information. But the two don't actually intersect. And so in some ways, part of the reasoning for talking about this in the book is to sort of describe how two different ecosystems sort of developed in parallel and didn't necessarily have the same sensibility. But if we go back to the health IT ecosystem that everyone is more familiar with, or the one that everyone thinks about, which involves patients and hospitals and physicians and payers, then what's interesting about that particular ecosystem is that we ended up with a system that was very transactionally focused, and transactionally focused around care, largely because most of the government reforms and the government policies that came out to try and supercharge information technology were very much based on ensuring that information was captured accurately for purposes of recognizing how to both cover people who needed to have care, as well as ensure that that resources were applied appropriately. And because of that sort of resource management mentality, and because of the fact that there was this need for accuracy in terms of what was actually being provided to patients, you started to see, in essence, a documentation pathway that became very much tied to making sure that billing was optimized, that payment was optimized, that we were recording what was happening to a patient in a format that would allow us to quickly be able to bill and get paid, and sort of use this as a way to sort of solve, in essence, the transactions of healthcare. The only challenge is that this actually ended up superseding almost every other use that you could have around information technology. For most people who come from any kind of a research background or from a provider of care background, your natural instinct is to think that if I'm collecting information, my reasoning for collecting information is really so that I can better understand either my patients or the disease or treatments, or even like public health or a cohort of patients. Your entire goal is to be thinking about information as a way to understand. But when information is being used to support ensuring that the operations are running smoothly and ensuring that you're basically getting paid appropriately, then you can sort of see how that would become the larger or the more dominant workflow that would end up occurring. One of the things that a lot of people may not be necessarily aware of is that in the 2000s, particularly around 2009, 2010, as part of the sort of affordable, as part of sort of the Recovery Act after the 2008 crash, the housing crash, one of the things that happened was an entire incentive and penalty system got built into our laws, which basically accelerated electronic health record adoption. And so when you start to distort a marketplace and force a technology to be utilized really rapidly, you have to rationalize why that's going to be happening. And part of what the rationalization was that it would basically speed up a fair bit of the ability to run transactions through healthcare. And so if you imagine you have this extra force that comes in, you can see very quickly that while everyone may have been wanting to take care of patients, really, to be honest, what was going to be the predominant activity that you would use information technology for, especially when you have electronic health records everywhere now, is to ensure that care is documented appropriately and that it is getting paid for appropriately. And that's literally why, in the end, we ended up with a system which maybe with good intentions to make it a little bit easier to exchange information, ultimately ended up just becoming a really good model for revenue cycle management and a lot less around patient care and also around research around disease and also around treatments.
And what about imaging data? So imaging data has always lived outside traditional EHR systems. Do you see that as an opportunity, a challenge for folks wanting to work with imaging data, either for evidence or AI development?
Absolutely. And you're right, it has been sitting outside for a while, along with like pathology reports, any kind of histology. A lot of different imaging type of reports have existed outside for quite some time. And that's largely because of the way the electronic health record was originally designed. It was designed to mimic a paper chart. And if you think about what a paper chart looks like, it's really just a folder, and you have a lot of different documents that you attach to it. So if you turn it into an electronic format, the first thing you're going to do is just digitize everything. And then you're going to slide it in there and it'll just be an attachment. It was difficult to digitize most images, so it was easier to just simply turn the reports into like more pieces of paper that would end up in electronic pieces of paper that would end up inside of a folder. And that's kind of like loses a lot of its great value. It just simply is there so someone can read it and then go find the actual image and then look at it and then make a decision. So it was really, unfortunately, not set up in a way that was easy for it to be used to do any kind of research or any kind of validation. What's exciting now is that with the way technology has improved going forward is the ability to create sort of high resolution images is much higher, but more importantly, we are now able to start to think about how do these images support our diagnostic capabilities, our abilities to watch the progress of disease. And so this last part of it is, can we move from simply a digitized version of first a report to suddenly an image to suddenly using it as part of the record? It does mean reimagining what a record can be. It does mean imagining what it's possible to be able to use it as just as much of a place of inquiry as someone writing a clinical note. And in that respect, there's something very exciting about that. This is kind of a little bit where generative AI becomes interesting because suddenly we have this ability to do something a little bit more at scale and to be able to start to combine our knowledge that comes from all of these different images in a way that allows us to create benchmarks, makes it possible to actually think about how we don't simply go from a direct translation of paper to electronic or image to electronic, but actually think of it as a source of data that we can use now to not only train models, but to actually make the record much more of a living kind of a product that's actually useful for both research as well as for care.
Yeah, that all makes sense. And we're actually at Segmed pretty excited that we are part of making it possible to bring imaging data now and not just have the EHR, but actually also being able to provide imaging data to researchers. So with the bringing imaging and other modalities like multimodal data towards the real world evidence and also AI training and validation space, what do you think is the added value that we can get to now compared to what we could do previously when we only had some text-based information?
I mean, again, at this point now, image, what do they say? A picture is worth 1,000 words. The
Hmm.
idea is that now you can actually start to maybe detect things that you wouldn't have detected before. If you were only looking at a report, it would most likely be a very summarized report. It would give you some general perspectives of ruling out a disease. It might tell you about some artifacts that it might be picking up, or artifacts that may not be there, but it won't necessarily delve deep into what possible sort of small pixels of things that you might be seeing that might not so be incidental, but might actually be something worth investigating. Most reports, again, are very summarized. And I think that what makes this really exciting now is that if you can process a lot of images in a more rapid and in a larger scale, you certainly start to see that what might look like an incidental artifact on one image might actually be something greater across a variety of images, or whether that's through a cohort or through an individual patient, is the possibility, the speed and the scale allows even static images to suddenly become diagnostic quality that it may not have had before. And this is what makes things exciting. You know, when most people think of speed and scale, they're always thinking in terms of pure efficiency, which is like, can I just drive, you know, the efficiency of like processing a lot of information so that I can just run it through so that I can get things, you know, covered and check the boxes and paid for. But if you can now stop and use this in a very different way and think of it as more of an exploratory tool, now something gets really exciting. And that, I think, is part of the excitement of the future of when if we think about images and if we think about what speed and scale can let us do, and the fact that we're not just simply, again, just translating something into a digital format.
Yeah, yeah. Yeah, I think one cool thing about imaging is you can always get more information out of it. You can look at it once, you can get something specific. The problem with the report indeed is it's just a summary, so you just get the information that's in there. But the image you can keep looking at again and say like, hey, maybe I'll look at a different part. Or if you do radiomics, you can look at specific features of images that maybe you hadn't looked at before. Your second part of the book, Ing, is about data research and real world evidence. And you write there about data curation on one side and then the perils of access on the other side. So, how do you think we should strike a balance between, or get the right balance between the data protection on the one side and enabling innovation on the other side? Because they kind of work against each other.
Yeah, they do. There's always been this inherent tension between patient privacy and the idea of making data very available so you can actually run analysis and do research on it. That tension has always existed. But even with that existing, we have found ways over the years to find ways to de-identify information, to remove sort of like the ability to sort of name who this piece of paper or this like document belongs to. So in some sense, we've already begun to do that. There are some ways we could have done this better. I will admit that part of it. But this concept of data curation is really around putting context into the game. One of the challenges that we have had over time is that, again, when we sort of de-identify information, we only simply remove like identifying marks. What we have never really done is make sure that whatever information we gain from that also has all the contextual aspects of it. And therefore, that's made it difficult to do research on. So identification, the whole privacy part of it is only one very small part of it. What's really more important is the data that you actually have within a chart or within a patient's journey actually usable and contextualized enough to actually begin to even run so any kind of real world analysis on. So I think that's one aspect of it. It has a lot to do with more of the quality of the data that you're using and rather so much the identification. I think that's just been something that everyone is fixated on as an argument for why things can't be combined together, when in actuality, the bigger problem is, can we actually start to improve this data quality first before we start talking about, you know, are we violating privacy? Because it's not about privacy there. It's really about, is there even enough context to do anything with it? That's one aspect of it. The second tension of this has a lot to do with because of patient privacy as being sort of the general rules around HIPAA and around sort of like non-violation for purposes that would actually end up harming a patient, we have also forgotten a little bit that the patients themselves have the rights to their own data, and that they are their own sort of center of gravity, of which they could basically, you could start to put data around, and that they also have the right to be able to ask for that information. One thing that is fascinating about the way we have built the health information technology infrastructure is that we really haven't involved patients in this in any way. They are sort of a recipient of care, and therefore if they want access to their data, they can maybe get some version of a record, and they are, but for the most part they kind of enter in maybe with their own information. They get information written about them, they can sometimes get access to it, but the ecosystem hasn't thought about them being a much bigger participant. And the only way you become a bigger participant of it is if you can access your information. So now you're not even violating HIPAA, but that you can access your information, but more importantly, that you can actually put context around your own information, and that you can actually put together a comprehensive enough journey of what you have gone through so that it's actually useful for even research. So going back to the first half of your question around, is it really about privacy or access? And it's really about, sort of the quality of the data. You could also argue that one way you can solve this problem is if patients themselves have the tools and the abilities to be able to not only grab their own data, but to aggregate it and to organize it and contextualize it in a way that would actually be improve the quality of that data so that it could be used for research. That is a way to kind of solve the problem between the need to protect privacy and also the need to be able to have access to good quality data for research purposes.
Now let's talk a bit about generative AI, which is the third part of your book. So in your book, you mentioned, and I'll quote a sentence from there, that today we live in a world in which generative AI is the dominant transformative technology that will affect all industries. How do you think generative AI is different from the past waves that we had in health IT?
I think there are a lot of things that are different about generative AI. A large part of it is its speed and scale. We are moving very rapidly. Nothing in health IT ever moved this fast. That's the first thing, right? So the challenge when things move very quickly is it means you don't have a lot of time to stop and think about what you're trying to do. So that is a little bit of the reason for sort of saying, if we're going to use generative AI in a very responsible way, and also take advantage of the fact that it's this transformative, that it can move this quickly, that we can start to put together pieces so much faster, how are we doing it? A large part of the last third of my book really explores this, the idea that we are not in the best position to utilize generative AI for multiple reasons. One, a lot of the data that we have is of variable quality. And so we train models in generative AI on the data. So if our data is of kind of variable quality, sometimes driven because our health IT infrastructure caused us to, in essence, optimize our data for billing, so it's not the same as clinical data, or that the data itself is kind of poor because it's missing pieces of information, and therefore it's of lower quality. If this is what we're using, data that's partially missing information, data that might have been coded for a different purpose, and trying to create very responsible analysis from that, and we're depending on teaching models off of this data, we do run this risk of actually compounding errors, and we have run the risk of actually making things a lot worse for ourselves. So I think that this is a moment to sort of say, listen, this is moving so quickly, this is moving so fast, its size and speed works in such a way that now you can take an error and propagate it all the way through very quickly, or you can take a false assumption and propagate it very quickly. How do we harness this and start to say, wait a second, let's think about how we build these models for that? So I do think that one of the challenges right now is the speed of generative AI means that there will be a tendency to apply it in shallow ways that will, in essence, basically drive more quick wins and transactions in order to justify, in some sense, why we keep spending and the speed of it. And the idea is, can those of us involved in research start to think a little bit more about, wait a second, how are we training these models? Is there a way to deploy this very powerful transformative technology to start to actually make it accelerate our ability to do research rather than think about, and the thoughtfulness of research, rather than think of it as this very shallow transactional application, which is probably the easiest way to use generative AI. So again, a transformative technology running really fast, you can take it in more than one direction.
And what are some practical examples or of agentic AI or AI humanism that you could tell us?
So AI humanism is really about sort of it's more philosophically, it's about protecting sort of the agency and the dignity of humans, right? And it's about the agency and dignity of patients, as well as in some respects also physicians who care for patients. It's been a principle that has sort of been part of medicine for, you know, since the beginning of medicine, I guess, or since the beginning of time. This concept of both agency and dignity. And one of the challenges with that is that when you start to do agentic type AI, or when you start to automate a series of tasks or a series of decisions and you daisy chain them together, it doesn't give a lot of room for there to be the opportunity to stop and think, is this what we're supposed to be trying to do? Is this end result something I can work with? Is this based off of a series of assumptions? But I think is the challenge is that's a different tension that we are now facing, right? How do you manage to maintain the agency and dignity of your patient? So how do you sort of preserve the sort of humanistic aspect of medicine in an AI world, when at the same time it is very, very seductive to link a number of autonomous decisions and also a number of tasks together, because you're going to go that much faster, right? You're going to speed through some administrative issue. You're going to make things go a little quicker. I think that's a new inherent tension that's about to do that is developing at the moment, in the same way there was another tension that existed before between privacy and access.
Yeah, that totally makes sense. I feel like there's a big, like historically, a big difference between how fast now Gen AI and AI in general is moving, and how slow actually adoption in healthcare and in the real world evidence space has gone indeed. So there's definitely an interesting dynamic going on there. We are already at 9:30 here on the West Coast, so I wish we had more time, but I wanted to really thank you, Ing, for joining us here. We are very excited to have you here and to hear more about your book, and everybody is excited about reading the book. We actually will do the lottery soon after this call. So one of the attendees, we'll reach out to you, and we'll probably post it on social media to let you know who won the book. So also to the attendees, thanks for joining. And of course, Aline, thanks for co-moderating as always with me, which is always great. So thanks everybody.
We're a pleasure.
Yes, thank you,
Of
everyone.
course.
Thank you, Mark. Thank you, Aline.
Yeah, thanks everybody, and I hope to see you all on November 6th, when we will have Dr. Pranav Rajpurkar from Harvard and A to Z Radiology with us. Have a nice day. Thanks everybody.
Bye. Thank you.